Thank you for the introduction and for the opportunity to present here today. I've got nothing to disclose. My name is Cesc. I work as a PhD student in the University of Cape Town, but I'm not South African, I'm Spanish. So if I speak too fast, you must let me know. And similar to my fellow speaker, Josejo, I also focus my research in the field of perinatal HIV exposure. And I think what's important for us, since we work in South Africa, is the fact that out of the approximately 16 million children estimated to be exposed to HIV worldwide, almost a quarter of them are residing in South Africa, so that's quite a high prevalent population in this country. And this is why we want to pay close attention to them. And why do we think it's important to look at this vulnerable population? Well, compared to their HIV unexposed peers, children with perinatal HIV exposure are at a higher risk of death and related morbidities, as published in a few meta-analyses a few years ago. And more recently, we also showed that these children are at a higher risk of neurodevelopmental delays, as published in our meta-analysis on the right, mostly in the language and motor domains. And we want to understand why is there such a relationship? What are the biological mechanisms or pathways that can justify such association between maternal HIV status and child neurodevelopment? We are basing, sorry, because this might be a bit tiny, the font, but we are basing our research into quite a well-established and investigated theoretical framework that poses that people living with chronic infection suffer from immune dysregulation. In the case of people living with HIV, in the case of people living with HIV, this can happen despite successful antiretroviral therapy. And in the case of pregnant women living with HIV, this immune dysregulation is referred to as maternal immune activation, which is a storm of cytokines and inflammatory mediators that can cross the placenta and impact the developing fetus. Now, there's multiple systems that can be affected by maternal immune activation, including the developing immune system and the developing nervous system through pathways such as neuroinflammation. And what's interesting here is that these two systems are in continuous crosstalk, not only during fetal development, but also postnatally and into childhood and adulthood. And what happens here is that children with perinatal HIV exposure, we believe that due to maternal immune activation, they are more prone to be overly reactive to postnatal or second hits, such as psychosocial risk factors, antiretroviral toxicity, or even postnatal infections. So our group has tried to put together the pieces of this puzzle through different investigations looking at maternal and child immunity, child neurodevelopment, as well as child brain development, looking at neuroimaging data from our cohort. But up until now, we hadn't addressed the gap of the relationship between maternal and child immunity and child brain development as seen through brain imaging. So this is the aim of our study. We asked ourselves whether serum marker levels measured in pregnant women and their children would associate with neurochemical composition in the brain of these children, and whether there would be differences based on maternal HIV status. So I'm part of a longitudinal birth cohort study called the Drakensberg Child Health Study. It's led by Professor Hedazar, based in Western Cape, South Africa, and we're working with a low socioeconomic community with a high prevalence of HIV and related risk factors. Within this longitudinal cohort, we conduct what we call the neuroimaging sub-study, in which we've been inviting children to undergo neuroimaging at different time points, from 6 to 10 weeks to 6 to 10 years, and it's still ongoing now into adolescents. And for this presentation, what I'm going to be focusing on is children for which we have available neuroimaging data at 6 to 7 years of age, as well as maternal and child blood immune measurements at all previous time points. So for those of you who are wondering what it looks like to be imaging children in a neuroimaging facility, this is a representative picture, and you can see that most of the time our children are quite happy to undergo brain imaging. And among the different modalities that you can use when doing magnetic resonance imaging, there is one modality which is called spectroscopy that allows you to select a specific area of the brain and get an estimate of the neurochemical composition of the chemicals, or neurometabolites as we like to call them, that exist within that area of interest. And this is what we measured in terms of neuroimaging. We measured neurometabolites, or we can call them here brain markers, of different things. but I'm going to be focusing on mainly two neurometabolites. One of them is a brain marker of neuroinflammation, and it's called myo-inositol, and another one is a brain marker of neuronal health, and it's called glutamate. In terms of the blood markers, what we measured is circulating levels of pro- and anti-inflammatory cytokines using Luminex, as well as serum markers of neuroinflammation and monocyte activation using ELISAs. And just jumping into the results, this is a quick snapshot of some of the sociodemographics that we collect for our moms and children. You will see that the groups are largely comparable between them, with the only significant difference that children with perinatal HIV exposure were a little bit older at the date of brain scan, which we correct for in our analysis, but the difference was of 1 or 2 months. All mothers living with HIV in our cohort were on antiretroviral therapy, 86% of them on efavirenz-based triple therapy. So first, we looked at differences in blood markers between moms living with and without HIV. And I'm displaying here the whole table with the results, but I'm just going to highlight the ones that were significantly different, which were pro-inflammatory GM-CSF, monocyte activation marker CD14, and neuroinflammatory serum markers lipocalin-2 and MMP9. The anti-inflammatory cytokine IL-13 was statistically significant before correcting for multiple comparisons, but it did show a trend after the correction, so we thought it was good to highlight here. For children, because we had measurements at different time points, we decided to use all of them and look at the trajectories of these markers and whether there would be any differences between groups, which we found. There were differences in pro-inflammatory cytokines, IL-1 beta and IL-5, as well as anti-inflammatory cytokine IL-10 and monocyte activation marker CD14. And now, up to the juice of the study, what we looked at is cross-sectional associations between immune markers and neurometabolites. So basically what we did is we ran linear models, we corrected for multiple comparisons, and those results that survived the correction were included in adjusted models to account for child age, child sex, and voxel composition. And I'm going to show you now a table with all of the statistically significant results that survived all of these steps, including the adjustment. And this table is extremely busy, and I do not intend to go through it one by one, but I just wanted to highlight that we did find some associations between maternal blood markers during pregnancy and child brain outcomes at mid-childhood, but we did find a lot of associations during early childhood to mid-childhood measurements and neurochemical composition later in mid-childhood, especially at blood marker time points 3 years and 5 years. And what I'm going to do now is I'm going to highlight results from 2 markers that were different in the group comparisons and that also showed associations here. So the first one is anti-inflammatory cytokine IL-13. So both maternal and child levels of this blood marker were associated with levels of the neurometabolite or brain marker referred to as marker for neuronal health. In case of the HIV unexposed group or the control group, this relationship was either positive or null. So if it was positive, it meant that more anti-inflammatory state, either during pregnancy or early childhood, meant more neuronal health in mid-childhood. But this relationship was disrupted or inversed in the exposed group. And then when we look at monocyte activation marker CD14, levels of this marker during early childhood were associated with levels of the brain marker for neuroinflammation in mid-childhood. And again, this got opposite directions of association in the exposed and unexposed group. In this case, children with perinatal HIV exposure, if they had higher CD14 in early childhood, they had more neuroinflammation in mid-childhood, and that was inversed in the unexposed group. So we're happy to see these results because not only they are very exciting on their own, but they are consistent with and build on previous findings from a similar study that we did looking at the neuroimaging data or brain chemical data from these same children at 2 to 3 years of age, where we saw consistent serum markers and associations with metabolites as well as the direction of association. The only thing that we would like to note is that at 6 to 7 years, we saw many associations on the child brain markers and the child neurometabolites, whereas at 2 to 3 years of age, it was mainly the maternal blood markers that were associating with child neurochemistry. So as a take-home message, we demonstrate that there are alterations in neuroimmune crosstalk and that these might be due to the perinatal HIV exposure of these children. The alterations persist into mid-childhood, but there's a developmental shift from maternal to child serum marker influence. And because we're seeing consistent results, we wonder whether we are actually looking at candidate pathways for further investigation, and if this would be a potential link to neurodevelopmental outcomes, which will be our next step in the analysis, to see whether these identified neuroimmune crosstalk pathways have any association with neurodevelopment. And I'm close to the end of the time, so I just want to thank everyone in the team, as well as the moms and the children, for their participation, and I will also be happy to answer any questions.